Hi there, I'm Josh Lumley. I am the Vice Chief Medical Officer for North Star Anesthesia, and we're going to spend the next minutes talking about organ donation. Okay, so let's spend a moment talking about lung transplantation. So survival rates are pretty good. It does start to trail off after 5 years. Donor selection, trauma victims with lung contusion less than 30. You want to look at a CT, X-ray, ABG, sputum stain to make sure that they're not colonized with MRSA. The graft, of course, is harvested and then lavage, and the lung can be preserved for up to 6 to 8 hours. Recipients are selected based on their disease and a reality that they will not survive more than 2 years without it. They don't have any pulmonary infections, which makes it difficult for your cystic fibrosis patients to get this because they're often colonized. Relative contraindications are previous thoracotomy, advanced age, steroid dependence. So you can do a single lumen transplant. A single lung transplant can be performed with COPDers. Double lungs are typically performed for cystic fibrosis, emphysema, or vascular diseases, and younger folks are more likely to get bilaterals. So you want to do a preoperative assessment, just like we talked about for a regular thoracic surgery, CT, PFTs, echoes. You want to put them on a physical regimen to where their BMI is optimized. These patients are typically they appear malnourished. Their BMI is oftentimes less than 20. Their BMI is very low. You want to see if they can optimize it and improve their cardiovascular function prior to surgery. Pre-op, you are pre-lung separation. You're going to use a double lumen tube versus a bronchial blocker. Ventilation, you want to avoid elevated PIPs. You're probably going to use pressure control ventilation. You want to prep for bypass in the event that you're using it, and you of course want a PA catheter to evaluate for right heart failure with clamping of the PA. Anesthetic management in this case here is avoid all right ventricular strain and maintain your cardiac output. So single lung transplant, we try to do it without cardiopulmonary bypass. So we ventilate the non-transplanted lung. It's typically done through a posterior thoracotomy. You've got to use a double lumen tube. Cardiopulmonary bypass during the transplantation is initiated if the patient is not tolerating one lung ventilation. How do we maintain it? We use one lung ventilation. We need to be careful to diagnose and check for pneumothorax. Check to make sure that the heart is tolerating PA clamping. And we may, in fact, in those patients that have severe pulmonary hypertension, just go straight onto pulmonary bypass prior to PA clamping. So for right ventricular failure management, you want to avoid anything that's going to increase our intrathoracic pressure. We want to increase our preload, utilizing milrinone and dobutamine, and we may in fact need to use nitric oxide or prostaglandin E1 to aid with that right heart failure. As I said, if a patient is not tolerating saturation or if there's worsening right heart failure, you're going to need to go on bypass. After transplant, there's going to definitely be VQ mismatch in that lung. There's going to be an exaggerated bronchoconstriction response, and then there's going to be impairment of the mucociliary function, so these patients require extensive pulmonary toilet. Afterwards, you want to keep them dry, you want to keep them dry, you want to keep them dry. Watch for pulmonary venous obstruction, look for PA narrowing, making sure that there's not a pneumothorax, and always, of course, like every transplant, looking for acute graft rejection. You want to get these patients up and walking as quick as possible and participating in an aggressive pulmonary toilet. Now let's talk about heart transplantation. 4,000 patients in the U.S. are currently registered for cardiac transplantation, only 2,500 transplants done yearly. It is a complex operation. So indications, there's a whole host of them, cardiomyopathy being number one. You can get ejection fraction less than 20%, amyloidosis, or a congenital disease. End-stage cardiomyopathy, diastolic and systolic dysfunction. They have decreased stroke volume, decreased cardiac output, decreased oxygen transport capacity, and a whole host of other comorbidities which make them difficult candidates to manage. So evaluating that recipient, you're going to do right and left heart cath. You're going to do a ton of labs, chest x-ray, PFTs. You want to look at their pulmonary function. Make sure that they don't have any substance abuse history, and make sure that they are not overweight. So unlike our pulmonary transplantation, where they were underweight, we want to make sure these people are not overweight. Cardiac donor. Brain death is necessary for any cadaveric donation. So it's defined as absent cerebral function in the brainstem reflexes with apnea during hypercapnia. So it shouldn't be any hypothermia, hypotension, metabolic abnormalities, or drug intoxication. And if you can't ascertain brain death using that aforementioned test, you may have to use EEG, look for cerebral blood flow imaging. Exclusion criteria: soft, greater than 55, HIV, hepatitis B, hepatitis C, systemic infections, malignant tumors, cardiac disease in, of course, the donor, and LVH or LV dysfunction on echocardiography. So what are some of the concerns you might have with this transplant? So there's a biatrial connection, which means there's less atrial contribution to stroke volume, so it's not coordinated. These patients, because it's a denervated heart, are going to have an acceleration of 95 to 110 beats per minute. Diurnal changes in blood pressure, those are going to be completely abolished. The diastolic dysfunction is going to be common because the myocardium is very stiff in transplanted hearts. From this point forward, you have to give them irradiated blood products, so they need to be CMV negative blood products. Post-op complications, they can have surgical issues at the site of injury, or they can have medical issues: right heart failure, left heart failure, rejection, or pulmonary vascular compromise. They could also have medical issues, rhythm disturbances, as we talked about, sinus node dysfunction or bradyarrhythmias, VTAC, atrial fibrillation, etc. So a whole host of rhythm dysfunctions associated with this denervated heart. Bradycardia in the cardiac transplant setting responds best to A, isoproterenol. So treatments of complications, so you want to treat whatever organ is dysfunctioning. So in this case here, you want to optimize oxygenation, optimize perfusion. You want to give all the drugs that are necessary to avoid right heart failure: dobutamine, milrinone, etc., and isoproterenol for the bradycardia. Managing right ventricular failure, as we talked about with the lung transplant, is a challenge. Milrinone, dobutamine, nitric oxide. Improve your hypoxemia, the acidosis, and if vasodilators aren't useful, you can in fact consider an RVAD. Post-op management, all of your immune suppression drugs are going to begin either the day after surgery or day 2 or day 3. You need to make sure you start them on Bactrim because for pneumocystis carinii prevention, and then start them on CMV negative blood products. You can in fact do an EKG every day, and if you need to do a endocardial biopsy, that can be done through the cath lab. Perioperative bradycardia in post-cardiac transplant patients can be treated by all of the following except. So the answer is D, ephedrine. So indirect agents such as ephedrine or those that work via vagolytic mechanisms will not be effective in increasing heart rate due to the total autonomic denervation. So indirect agents, ephedrine, they're not going to work. Bradycardia is the most common during and after cardiac transplant because of sympathetic denervation, or any injury to the sinus node or graft ischemia. So in these cases, these patients do have a lack of vagal tone. They're going to have a baseline heart rate, as we talked about, anywhere from 90 to 110. Without parasympathomimetic innervation, they don't have normal tachycardia or increased contractility in response to hypovolemia. In these cases here, epi and norepi may have an exaggerated effect. So again, of a whole variety of drugs that are going to act differently in a transplanted heart. Certainly the one that you really want to remember, of course, is ephedrine because it's indirect acting. So in our patients that do have a heart transplant, what's our anesthetic choice for them? So regional anesthesia, you can use them, but again, these patients don't respond appropriately to hypovolemia. So we want to make sure that if we're going to use regional anesthesia, we do it judiciously. You don't necessarily need an arterial line. It can be based on what type of surgery you're going to have. EKG can have a double P wave, and then do remember that the heart is preload dependent. They do not tolerate being intravascularly dry, so you want to make sure that they're adequately hydrated. Have epi and isoproterenol ready in the case that there's bradycardia. Atropine, as we said, remember there is no vagal input to the heart, so atropine is not going to work. And that is it. Thank you.